Hello again, everybody. Welcome back. This is our Chapter 8 discussion. Today we're going to be talking about neuromuscular conditions and disorders. We've got two parts that we've cut it into, half and half. I'll kind of give you some, at least make some markings on the video of when each one starts and stops and why we divided it into two parts. But for the purpose of this recording, I put them all into one. If you're my students listening to this and you're looking at the PowerPoints have been posted separately, but this one is everything all together in one. So here we go. So we're talking neuromuscular conditions and disorders. We're talking about the nervous system here. So first, before we get into any disorders, conditions, etc., we need to talk about what it is. This should be a refresher for you. Nervous system consists of your CNS, or your central nervous system. That's the brain and spinal cord, of course. And then you got your peripheral nervous system. That's going to connect your brain to the rest of the body, all the periphery of the body, thus the PNS, or peripheral nervous system. Now, that peripheral nervous system, that's divided further into the somatic system, which mediates volitional movement. That is, of course, a fancy way of saying voluntary movement. So any voluntary movement, so anything like when we exercise and we execute tasks, whether it's a bicep curl, an overhead press, something to that effect, we are using our somatic system. We are using volitional or voluntary movement. We are sending signals from our brain consciously out to the corresponding muscles in order to contract in such a way to execute those movements. So that's your volitional movement. And then your autonomic system, that is going to be your non-voluntary stuff. Internal organs, the enteric system, which regulates your gastrointestinal system. So again, those are things that we don't have conscious control of, but that's the peripheral nervous system breaks down into those two, the somatic and the autonomic. So we find out what it is. Now let's talk about disorders, just generally here, before we get into each specific disorder, or at least the most common ones that we anticipate that you might experience as a professional. That doesn't mean you might not experience others, but we try to pick out the most common, most likely. But the neuromuscular disorders that are the subject of this chapter, they are a result of a decline in the functioning of your body's nervous system and or the muscular system along with it. Now, these neuromuscular disorders, they happen for a number of reasons, and we're going to get into all that, but they can be classified as either progressive disorders or non-progressive disorders in nature. And what's the difference between the two? Well, progressive disorders, much like an exercise progression, means that something gets more and more. There's a more intensity as things go on. So progressive disorders involve a continuing and progressive deterioration of functioning. So over time, the functioning gets worse and worse. Whereas a non-progressive disorder, well, those don't get worse following the initial episode of disease or mechanical injury. Now, keep in mind that what we're talking about here, these neuromuscular disorders, we're also talking some that are based in injury. So it might be an acute event, a mechanical injury that causes this decline in functioning of the nervous system. So that's why we're kind of breaking this down into two parts. It'll make more sense to you when we talk about the etiology and how these disorders occur. There's a clear difference between the first half and the second half. A little bit more on progressive versus non-progressive. So those progressive disorders that are going to be the foundation of really part one of this talk are going to be your MS, or multiple sclerosis, Parkinson's disease, and muscular dystrophy. And then the non-progressive disorders in the second half of this talk, that's going to be stuff like cerebral palsy, stroke, head injuries or TBIs, and your spinal cord injury. So those are the topics that we're going to break down into for different conditions and disorders of this particular chapter. So we will start with the first one here, MS, as it is commonly known, otherwise known as multiple sclerosis. This is a neurodegenerative autoimmune disease. Say that 3 times fast. Now, for this disease. So what happens? What's actually going on that makes this problematic? Well, this disease results in a deterioration of the myelin layer that surrounds each individual neuron, or demyelination. And what this myelin sheath does, what this layer that goes around each individual neuron, is it helps to actually send the electrical impulses that control movement, that stimulate the nervous system. So it provides electrical insulation around the neuron, helps with that transmission, but when it is stripped away, those electrical signals that are necessary in order for us to move and function properly, well, they're going to weaken. The signals are not going to be as strong because there's not as much insulation, so the system is going to be affected in general. So when the myelin layer wears away and deteriorates, then we have problems with the rest of the body from a neuromuscular standpoint. Symptoms of it. So how do we recognize what's happening when it comes to MS? We usually start to see, because of inconsistent or weak nerve transmission, so those electrical impulses that need to travel all through the nervous system from the brain and all the way out to the muscles that correspond with the areas of the body we want or need to move. This includes things like fatigue, numbness, perhaps walking problems. You think walking and balance here, those require a lot of coordinated movements. It might even impact other areas of functionality, bladder dysfunction, bowel dysfunction. It might affect the vision, could cause vertigo, cognitive dysfunction, so issues in the brain, pain, muscle spasticity, so having some muscle spasms, depression. And depression, you would think, is probably a secondary result because of the deterioration of the rest of the body. So these are all some of those signs and symptoms that someone will see if they are approaching diagnosis of MS, if they're having the issues that correspond with it. Now, something that is good about this, while it is clearly a condition that is certainly impactful on a person's quality of life and has some major impacts potentially, the nice thing about it is that if you have MS, it is not something that is life-threatening, or it does not shorten your lifespan. You can adapt and live as long as a normal, otherwise healthy individual. So that's always a good thing. Not every disorder has that same distinction. Now, MS gets broken down into a couple different types. You've got relapsing MS, relapsing remitting MS, and that's 85% of cases of MS are this relapsing or remitting type, which consists of people that have it, they experience clearly defined exacerbations or flare-ups, and these could last a couple of days, they could last up to several months, followed by a remission, where there are no problems at all whatsoever. Symptoms either stabilize, or they're not getting worse, or they lessen in general. This is that relapsing remitting. You've got this period of time where it's worse, things are flaring up, it's clearly been exacerbated, and then you've got times when it goes away. So that's relapsing remitting in the majority of cases here. Half of those, however, over the course of 10 years, they might be considered secondary progressive, because after that length of time of going into it and being out of it, we do see a more gradual decline or impairment in functioning. So the amount of disability by this does worsen over time. That neurologic function does get worse even with the relapsing remitting. So when you've had it for a long period of time, it can be considered, this term here, secondary progressive. And then primary progressive is only 15% of cases, and this one is obviously more severe because there is a continual progression, a continual worsening of that neurologic function. There are no relapses, it just gets worse and worse as time goes on. Fortunately, it is a much smaller part of the diagnosis, only 15% of cases. So how does somebody get this? What causes it? Well, they don't really know. There are a few hypotheses, a few possibilities. Could be something to do with the immune system. T cells attacking the myelin sheath, which results in scarring of the nerve and then impacting those electrical impulses. Maybe it's environmental. Incidence is higher when living farther from the equator. So if you live in really northern latitudes, up in maybe northern Canada or other places in Europe or around the globe that are considerably far from the equator, might be something related to a lack of vitamin D. So not being close enough to the sun and absorbing vitamin D from just being outside and being in the sun. That's a possible cause. Perhaps it's viral, infectious. That can cause demyelination, so that might be something to be considered. Or it could just be something that you were unlucky enough to have passed down from relatives. Having relatives with MS, they have seen through research that that does seem to increase the chance of being affected, which obviously lends credence to the idea that perhaps MS might have a genetic component associated with it. But altogether, they're not really sure. More research, more time, more studies need to be done. So how does it get treated? And again, remember, this does affect us because the medications that people take for each and every one of these conditions and disorders, they have impacts on the body when it comes to their side effects or just the effect of what they're doing, the direct effect. And those are things we might have to work around as exercise professionals working with these clients. They might use disease-modifying interferons. These are immune-defending proteins, and they help to reduce the frequency and severity of these attacks where they're not functioning properly. However, there's a potential for a reduced capacity of exercise as a result and a reduced capacity to recover between training sessions. So they're going to be more fatigued. They're not going to be able to go as hard or as long, or even if they do, maybe they don't get their body back to baseline. You need a little bit more rest time. Corticosteroids, those are something used even in the general population, somebody with some kind of injury. That's used to reduce inflammation. That might also, though, however, a side effect could be that reduces exercise capacity. And then other medications. It really depends on their symptoms. We already know there's lots of good charts and tools and things. If someone is on a medication, you have a responsibility of looking it up and making sure that you are tailoring your exercises to the limitations associated with these various medications and their symptoms or side effects as resulting from taking them. Now let's talk the good stuff. What does exercise do to help? Well, better quality of life is really what it's all about. And that can be said of nearly every condition we've talked about. However, unfortunately, it is not a miracle drug, and it does not necessarily have anything to do with the slowing down of the progression of this disease. Resistance training, however, so getting in, doing some lifting, has been shown to be effective at improving strength and power, which is always good, muscular endurance, fatigue threshold, so the point at which they actually get fully fatigued and tired, their walking speed, and balance. And again, that will result in a better quality of life in general, especially considering all the issues they're dealing with as a result of this particular condition. Now, I'm not going to, on really any of these, I'm not going to go ahead and read you each of the individual things, but I will give you some of the special considerations that are there for each disorder. When it comes to, recommended percentages and times, that's stuff that you can always go to these tables for. And that's what these lectures are for. You can go back and stop the video and find this, or you can always just open your books up to the page that we're at and find it. And those recommendations on table 8.1, that's going to be located on page number 271 of this text. Some things to know, though, for special considerations. People that have MS, they might benefit from using seated resistance machines as opposed to upright free weight activities if their balance is compromised. Well, that makes sense. If they've got balance issues, having them up on 2 feet then become a fall risk, and then they can get hurt. We don't want that. So set them down, let them do their resistance training that way. Non-weight bearing aerobic exercises, same reason, right? Balance issues, like recumbent cycling or aquatic exercises, and they're giving you a little temperature recommendation here. Water should be greater than 85 degrees. 1 session per week, light to moderate intensity. Again, that's the kind of stuff that's in that table. Static stretching is preferred over dynamic stretching. Again, balance issues. And look at that. We're looking at 15 repetitions, 1 to 3 sets of 4 to 8 exercises. Total body. Other precautions. You saw a little bit of this when they just mentioned recommending being in a pool and having greater than 85 degrees. Reason being, exercise only in cool temperatures. So that's a really moderate temperature range, 72 to 76 degrees. That's real nice. And well-ventilated areas. The reason being is that people with MS, they are very, very sensitive to internal and external heat. So I suppose we all live here in Florida, maybe not the best place in the world for people with MS to go to because that heat is going to be problematic. Good hydration, drink lots of water. You don't want to have any increase in body temperature, and having more water in the body is going to help prevent against some of those issues. And if you see a full-on flare-up where they really start breaking down and they're not able to function very well, immediately stop. Restart only when this has fully subsided. And remember, this person's going to know more about their disease than you are. They will also come equipped with a clearance note, with doctor's recommendations, all that stuff. So this is just some stuff to keep in mind now as you're learning about this. Always, always, always have good resources, have your documentation when you're working with someone with any of these conditions we're talking about. You might need to bring in some adaptive equipment, things to help you out. Wheelchairs, canes, and walkers, these are all going to be nice instruments or adaptive devices that you can implement because they are going to be a bit fatigued. So that's it for MS. Let's switch now to Parkinson's disease. Now, as of the class in which I'm teaching this, we have already done some work looking at Parkinson's disease, not so much in defining what it is and going over these specific recommendations, but hopefully, whether you're in the class as of the recording date, which is in 2018, or you're in one of the future classes where you might watch and listen to this, there are some great programming avenues for people with Parkinson's disease. And we do work currently with a gym in the area that hosts a program called Rock Steady, which is a boxing program that is designed specifically for patients that have been diagnosed with Parkinson's. And I'll talk more about how that fits in as we get in there, because obviously in this book, the NSCA doesn't say anything specific about boxing or about Rock Steady. But remember, all programming should be fun. It should be engaging. It should give people purpose and make them want to come back and do it some more. It's a great example. So whether you're reading this or listening to this from far, or you've taken my class now, or you're taking it 2 years from now, whenever the case may be, look into Rock Steady Boxing. Check out, there's some great videos. They've done some great stuff in the news. That's how people know about it. And this is a great exercise programming choice for Parkinson's disease patients. Let's just talk what it is, and then you'll see how it all makes sense. PD is the second most common neurodegenerative disease behind MS. This is why we talked about that first. Progressive brain disorder is what it's characterized as, and it's caused by the death or impairment of neurons in a particular region of the midbrain, the substantia nigra region of your midbrain. What happens in that region? Why is that of concern? Well, it's a regulator of motor, emotional, and cognitive behaviors. The neurotransmitter dopamine, which is one, if you've ever taken any psychology classes, that neurotransmitter is one that gets brought up quite a bit. Now, this lack of dopamine normally produced by these cells, that will cause some of the very recognizable signs and symptoms of Parkinson's disease. And what we're talking about here, so what are those hallmark signs? Well, tremors of a limb. That's where you see that kind of, it looks like a shaking. Those are considered tremors. Bradykinesia, or slowness of movement, slowing down the way someone moves. Muscle and joint rigidity, so not a lot of flexibility and movement in muscles and joints. Poor balance, all not really fun things to deal with, but they are all nonetheless significant signs and symptoms of Parkinson's disease. Diagnosing the disease is difficult. There's not one single test. Patients are going to be subjected to a battery of tests and really kind of look at a number of things to help get this diagnosis, but it is not one that is handed out very easily. Much like all the other things we're talking about, they take some meds, but usually they're going to be for correlated or comorbid conditions. No current medications to slow or stop the progression of PD. Most of them are due to a lack of dopamine, so they might give you this medication called levodopa, which works by being converted to dopamine in the brain so that there's more dopamine in the body. However, side effects, right? No free rides with any medication. Nausea, loss of appetite, lightheadedness, confusion, hallucinations, and reduced blood pressure. All things that really help somebody want to be very active and exercise quite a bit, right? This is why you got to know these meds. Again, don't memorize them, look them up. Now with this, because of this kind of medication, their capacity for exercise might be limited, or the risk of injury might be greater. If they're confused, they're hallucinating, if we're talking high blood pressure or reduced blood pressure, it's not getting everywhere it needs to go, well, those can be problematic, and that might make injuries a bit more likely. There's also anticholinergic medications. These are used to reduce spasm activity in the muscles, but increased risk there because those might actually cause blurred vision, drowsiness, confusion. There are COMTs. I'm not even going to bother. You won't remember it anyway. But COMT inhibitors are used to prolong the duration of activity of levodopa. So those two medications might be prescribed concurrently with one another. Usually someone is not, if you have a client and they come to you and you say, hey, what medications are you taking? Notice that you already even put it out there as a plural. Typically, you're going to see people on multiple medications to deal with multiple conditions and or side effects resulting from the other medications. More drowsiness and dyskinesia, abnormal or involuntary movement. Scary stuff. These meds, you know, for all the good they do, they've got some pretty funky side effects too you got to be worried about. So how can we help? What can we do? Now, it doesn't really get into the different classifications of Parkinson's disease here, but just know that there are varying levels of disability when it comes to Parkinson's disease. They get classified into 1, 2, 3, or 4, and classification level 1 and level 2 are going to be more high functioning, so they don't have quite as many impairments. It's a little easier to work with these folks. Whereas if they get into the 3s or 4s, if you're going to work with anyone in that population, that's going to require some really significant modifications. And really any exercises they might be doing might be more focused exclusively at movements and things that they'd be doing in their daily life versus just kind of traditional exercises. So we'll kind of stick and talk mostly to the higher functioning levels. Resistance training has been shown to increase muscle strength in Parkinson's patients, increase their mobility. Remember, we said they were kind of rigid and stiff. Their walking capacity, that's always good too. Keep the cardio going, the aerobic exercise, improve their endurance, balance, fat-free mass, some more lean tissue, which is always good. That's also good from a metabolic standpoint. And successful protocols, so types of programs that you might come up with. And this is where I'm going to get a chance to say something again about rock steady boxing and where it fits. Because while it's not mentioned here, a component that's really the big part of it is balance training. Again, if their balance is affected, you want to improve it. High intensity training. That's really, if you've been to a rock steady class or if you go and watch it or see it even in a video, it is basically high intensity interval training. They're just using boxing as a medium. They're putting gloves on somebody, letting them hit stuff, but then they're also doing other high intensity exercises. It's programmed very similar to boot camps or high intensity interval classes that you might take for able-bodied folks. It might be scaled down, modified a little bit, and it's working exclusively with these patients. But that high intensity interval training, that is helpful, and it keeps them functional and moving better. Moderate volume, high load training, and high force eccentric training. So these are all different options that you can use for someone if they come to you and they've got Parkinson's disease. Same kind of recommendations for all older adults. There has not been enough research done as of this time, so I'm reading this here for you in 2018, to establish specific recommendations. When it comes to anything, though, always focus with those multi-joint exercises. You get a little more work in, and it's a little more functional, right? Movements that are going to be used commonly in daily life. Start with moderate resistance, increase as they tolerate it, as they get better. And again, these recommendations, table 8.2, which if you're following along in your textbook, you can find that on page number 276. There you go. Like I said, though, balance training. Balance, 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 because fall risk is a big concern of these folks. So work on their balance. Last thing here I'll give you, because again, I'm not going to read all the, for 30 to 60%, etc. You can find that in the tables. That's fine. Things to keep in mind, though, some real considerations. Emphasize safety. So don't, these folks, for a lot of them, they were at one time able-bodied. Maybe they want to go after it a little harder, a little more intense. Emphasize the importance of safety. Maybe slower walking. Less coordination and poor balance can increase fall risk. And typically this is mostly older adults. They're also at higher risk for issues with bone health, right? We talked a little bit about osteoporosis, and then they're more susceptible to have fractures. So less coordination and poor balance are bad. Slow them down. Make sure their movement is good before you get a little too crazy on some of this stuff. Now, interestingly, here's another significant contraindication. Treadmill walking is contraindicated. However, overground walking, or just walking around somewhere, or out in public, on a track, on a sidewalk, wherever that may be, or stationary biking, those are preferable methods for aerobic exercise. But just think for a moment while you're sitting listening to this about the coordination that it takes to walk on a treadmill. I know we take it for granted. It seems like something that's actually pretty easy to do, when in fact, it's not. If you've ever been in a gym and your treadmill is located underneath some televisions. I know when I was in grad school, our rec center, I used to run on the treadmills, and sometimes I'd be in there on a Sunday afternoon, football would be on, and I'd be doing my warm-up or even my run, and I'd be jogging on the treadmill, and I'd look up, and there's a TVs ahead of me, and maybe I was watching a game on the TV up and over to my left. So I'm not really looking at my machine or my or at the belt which I'm running on, and I'm watching somebody break away, a running back or a wide receiver, and they start kind of drifting off to the side, and you're watching them, and what you find is that your body sometimes subconsciously starts to follow the path of whatever you're watching and you're distracted by. I've had incidences where we're watching football on just like that. I've almost fallen completely off of the treadmill. Now, if somebody's got movement impairment and they've got stiffness in their joints and their muscles, and they maybe aren't able to have quick reflexes and kind of move all that quickly, a treadmill, while it's good in some ways because it does the work for you, if you're not keeping up with that treadmill, you are going to go down, and you are going to go down hard. So treadmills are out. Walking is in, but just take them someplace else. This is where, if you've ever been inside of a nice mall and you see the old folks walking around, they have the mall walkers. It's a safe, climate-controlled environment where you can, and it's large, you can get a lot of steps in during the day. If the outside's not an option for you, that's something that you can do. Other office buildings inside, whatever the case may be. Treadmills out, overwalking in. You can use stationary bikes. There's not as much of a fall risk on those. So I wanted to spend a little time there because that's an area that I think is of some importance here, something to keep in mind. More recommendations. Less busy times of the day, that can avoid problems with adaptations to the environment. You don't want people getting in your way. You want them to be able to adapt to what's happening. Talk with their physician, get their doctor's clearance form about the timing of medications, namely because when they take their meds, their symptoms are a bit more controlled immediately after they take that medication. So maybe those are the best times to take them through an exercise program. Watch heart rate, blood pressure, and body temperature because of the autonomic nervous system dysfunction as well. And you don't want to have them go into a state of orthostatic hypotension. Now, orthostatic hypotension is a state where blood pressure suddenly drops, and that's that hypotension, low blood pressure. It usually will drop significantly if you go from like a lying down or seated position up to a standing position. So don't have a lot of ups and downs in any kinds of programs with these folks as well. And if there is any, that's why you want to kind of manage and keep an eye on that blood pressure. The next one, our next topic, condition, disorder, stroke. A stroke, otherwise known as a cerebral vascular accident, is a very serious vascular event in which there is a loss of neurological functions of the brain related to an acute interruption of blood flow to the brain. So if the blood is not getting to the brain, we've got problems, and that's going to impact the neurological functioning of the brain. Think of it this way. I forget where I heard it this way, but I'll share it with you. We know what a heart attack is. A stroke is basically a brain attack. Two main variations, however. You've got an ischemic stroke, and this is the majority of them, 80% in fact. That's where blood flow to the brain is interrupted by a physical blockage. So something physically blocks off the blood flow to the brain. A hemorrhagic stroke resulting from a hemorrhage occurs as a result of bleeding in the brain. The other form of stroke is a TIA, or transient ischemic attack, also known as a mini stroke. So that makes up that remaining percentage that's not accounted for. Those could be from temporary blood clots. But again, if they get in the way of blood getting to the brain, we could see some issues when it comes to neurological functioning. So the brain needs stuff from the body, much like all the rest of your organs and body parts. Nutrients like oxygen and glucose for brain function, they are not stored in big amounts in the tissue of the brain. All right, so they're not keeping some stashed away for a rainy day. So the amount of time for which the blood flow is blocked to the brain is crucial when it comes to seeing how much of an effect this will have in terms of functioning. Obviously, the longer it is blocked, you can expect the more damage that will result. Stroke on one side of the brain, so if you have a stroke and it happens on the left side of the brain, well then you will have deficits on the right side of the body. It works contralateral. So if it happens on one side, your deficits will show up on the opposite side. Paralysis on one side of the body from a stroke on the other side of the brain, where if you've ever met anyone with a stroke, if you've ever heard anything about it, learned about it before, people talk about being paralyzed on one side. That is a phenomenon known as hemiplegia. So how do they happen? What are some issues when it comes to stroke that we need to be concerned with, maybe from a prevention standpoint? And that's why good health is important. Well, some things are lifestyle related, others are not. But a variety of factors do seem to increase the risk for a stroke. They are as follows. Smoking, high blood pressure, inactivity, obesity, age, could be hereditary, so passed down in your genes, and race. Believe it or not, for whatever reason it might be, they have found that African Americans are at greater risk for stroke than other populations. So all of those are factors. Again, some of those, high blood pressure, smoking, inactivity, obesity, we can control those. All the rest of the stuff, well, not so much. Ischemic strokes are going to be caused by either thrombosis, embolism, or global ischemia. Now, thrombosis is a blockage of a brain blood vessel, usually from a buildup from fat and cholesterol in the blood vessel lining. Embolism is a clot that travels to and lodges itself in the brain. And then global ischemia occurs when the whole body ischemia, so when blood is not getting out to everywhere. That can result from an event like a heart attack, a myocardial infarction. That's what an MI is. leading to catastrophic loss of blood pressure. And then, of course, not only is the entire body affected, but the brain also is going to be affected by that. So 3 different mechanisms there. Hemorrhagic strokes, some ones resulting from hemorrhage, the rupture of a blood vessel because of damage to the vascular structure. It could be because of a cerebral aneurysm, or it could be from chronic high blood pressure. So that's why keeping your blood pressure nice, low, and healthy is important. It can lead to strokes. Aneurysms, we mentioned that word there. That's areas of ballooning on a blood vessel. It's due to a weakening of the vessel wall, which may, again, if it balloons up, that balloon can rupture and therefore then cause bleeding in the brain. And that's going to be problematic and lead to this type of stroke we're talking about. Meds for stroke patients. Well, sometimes because of whatever the reason may be of how they had their stroke, perhaps they take some blood thinners, right? Those are going to be put in place to reduce the chance of additional blood clots. We certainly don't want any more damage to get done, so blood thinners help to make it so that blood clots don't occur. However, because the blood is thinner and won't clot even normally, so in a protective manner, like in case of injury, because clotting does have a purpose in our body, the chance of bleeding complications. So if somebody bleeds while they're on blood thinners, that's a problem because they're not going to easily be able to stop. So if they are on blood thinners and you're making their exercise program, perhaps avoiding vigorous physical activity or putting them in situations where like they might be bleeding either internally or externally, that's not going to be such a good thing. Blood pressure meds, those get commonly prescribed. And again, look up the side effects for all of those, and those will guide you in your exercise selections. Now, stroke victims, we mentioned some lifestyle areas that might also be there. So they are likely going to be people that also have other comorbidities that need to be addressed. Like typically you don't have a stroke for no reason. Maybe it's because you smoked, and or maybe it's because you had high blood pressure. Maybe you had high blood pressure because you were obese, and maybe because you were obese, then your blood sugar got high and you developed type 2 diabetes. You see how these things can stack one on top of the other and be comorbidities with each other. We talk about them in isolation as we're learning, but in reality, they can all be presented at once. And if you're an exercise professional, you need to take that knowledge about each and every one of these and all the meds and stuff that goes with them and come up with something to help better this person's life. It's a challenge, but you have the tools. You just need to know a little bit about each of these things to kind of help inform your process. So how do we help? Well, exercise is good, man. Everybody knows that. Exercise is medicine. However, when someone has a stroke, they might have some intolerance to exercise. And also because of whatever issues that result from the stroke and the severity of it, they can become pretty deconditioned, or perhaps their gait, their walking pattern, the way in which they ambulate and move might be inefficient. So that is something that gets in the way of traditional exercise. Clinical exercise programs, so stuff they're going to do in clinic, they're going to be do under the supervision of more advanced personnel than us necessarily. That will look to help to improve some of those motor deficits resulting from the stroke, and then increase their ability to carry out those activities of daily living. That's why it's important with exercise selection that you pick things that make sense, that people can use the strength and the gains they get from your exercises to be able to use them in their daily life. Most recovery from stroke will take place within a 9-month span. Aerobic training does improve aerobic capacity similar to those without stroke, so similar adaptations, which is good, and that will reduce energy cost at a submaximal effort walking. So, and that will also, the walking is good because that will help to improve the way that they walk. Remember, with paralysis and the effects on the opposite side of the body, they might be walking a little funny as a result. The more you get them walking and working, the better they get at that movement. It's going to be better for them on the whole. So what can we use? What kinds of equipment? Well, treadmills with handrails or treadmills with a harness, perhaps, a little more advanced. That's used to control the loading and the intensity of exercise during recovery. So again, this is definitely some clinical setting issues. resistance training, strength, power, muscular endurance, and motor unit activation. Especially that motor unit activation is going to be important. The other one, strength, power, muscular endurance, well, those are the same effects that it has in every population. There you have it, some recommendations of how long. Similar programming to that for elderly people. You can always go back to this video, or just kind of looking at things, go and see the table for this located in your book. For you, that'll be on page 293. Now keep in mind, we jumped around a little bit, and we're going to divide them up a little bit further, but I want you to make sure that, in addition to listening to these lectures and taking these quizzes, like, I'm not giving you every single condition in here, okay? I'm giving you ones that are going to be more common, things that you are more likely to witness and encounter, even as just a regular person working in our field. That doesn't mean that you don't still have a responsibility, especially with some of those quizzes that come from the certification book, of actually going through the chapter yourself and familiarizing yourself at least a little bit with some of the other disorders and conditions for chapter number 8. Last thing here on stroke, unilateral movements involving the affected limb should be used. So I know we always say, oh, whatever you do to one side, you should do to the other. Well, if somebody has significant impairment in one side of the body, in this case, it is okay to just do something on that one side of the body. When it comes to what equipment to select, it all depends on how impaired they are. Maybe recumbent bikes or steppers, maybe reciprocal push-pull devices like an elliptical would be good. There are these cool specialized gloves that can help with grip strength. These things, though, are probably going to be used more likely with occupational therapists or physical therapists, but there's some information for you there about these cool gloves that can help to work with grip strength. And resistance training machines, you probably pick ones with good torso support or chest straps, right, in order to secure them properly onto the machines. And then as they progress, as they get better, a little more controlled movement, you can then progress to removing some of those straps. All right, part number 2. So those were all things that kind of just happen to you, that are a little more, either you're born with it or it just kind of comes on later. In the case of stroke, maybe it's lifestyle, maybe it's congenital, right? It's something that comes through your genes. In part 2, we're going to look at some other conditions that are more acute in nature for the most part. And we'll keep it at the 42-minute mark that we switch from part 1 to part 2. TBI, traumatic brain injury. That's an acquired injury to the brain that takes place when a sudden traumatic force causes damage to the brain tissue. TBIs can be classified based on severity, ranging from mild, moderate, or severe. So that's what TBIs get classified as: mild, moderate, severe, depending on how hard you hit your head, right? You hit your head and the brain actually succumbs to an injury as a result of that impact. And actually, when it comes to concussions and that sort of thing, things that qualify under TBI, sometimes you don't even get hit in the head. It might just be like whiplash and just violent jarring movement where the brain is shaking around inside the cavity in your skull, bumping into the walls. These are graded in the emergency room. They look at a couple things when they're talking about how severe the TBI is: whether the injury caused unconsciousness, how long unconsciousness lasted if it did occur, and then other things like their verbal, motor, and eye-opening responses to different stimuli. So that's going to be the way that they check to see how bad it is. Mild TBIs, which include concussions, which are a big part of our discussion whenever we talk about injury prevention. This is certainly part of the conversation, and of course it is a hot topic in all the sports. But concussions either do not result in a loss of consciousness, right? A lot of them do not, but some of them can. The individual can be unconscious for about 30 minutes or less. Usually the symptoms resulting from a TBI like this, a concussion, a mild one, might be happening immediately, or there actually might be a delay, sometimes up to several weeks. Moderate TBIs. These result in a total loss of consciousness, more than 20 minutes for sure, fewer than 6 hours. There are physical, cognitive, and behavioral performance effects. They might be impaired for months. In some cases, if it's a little more on the severe end of the moderate part of our spectrum here, it could be potentially for life that they have these issues, physically, cognitively, and behaviorally. Yes, folks, damage to the brain, getting hit in the head a few too many times, and significant trauma can actually affect your behavior, affect your personality in a sense. That is a real thing. And a severe TBI is from a very, very traumatic head wound. It doesn't have to necessarily be something that penetrates the skull. It can be a closed head injury or a penetrating injury to the head. This will result in unconsciousness lasting more than 6 hours, and the more severe injuries result in significant damage to brain tissue with a lot of behavioral impacts and a lot of physical impacts, and it's going to involve and negatively affect nearly every aspect of this person's everyday life. Most common causes: falls, motor vehicle accidents, being struck by an object, or being assaulted. So getting hit in the head in a fight, or or somebody attacks you. The impact itself causes the initial damage, but depending on what happens to the brain and the severity of stuff inside, the altered blood flow or the inflammation that is going on in the brain and in that cavity of the brain can actually cause some secondary damage as well. So that's you get a 2-for-1 special there, depending on how bad it was. However, the secondary damage is more responsive to therapeutic intervention. Not a whole lot you can do about that initial impact. No meds for actual brain injury. Right? There's no magic pill to help with your brain being injured. However, symptoms that occur, well, there are some medications for that. Pain meds, anticoagulants like blood thinners, I remember the risk of bleeding there, antispasticity drugs, anticonvulsants, so like anti-seizure medications. Those have a risk of fatigue, digestive problems, dizziness, blurred vision. Remember, side effects, every single medication we talk about for the most part. They might take opioid or narcotic analgesics, so things to kind of help numb some of the pain in the areas. And those have significant effects as a result of the side effects. All right, so for aerobic training for TBIs, perfectly safe and effective. Does all the things it should do for that it does for able-bodied people, and especially the big thing here, reduces depression. Right, all those positive endorphins. It can be as effective as it is for individuals without TBI, so no restrictions here. When it comes to resistance training, jury's out again on this one. No evidence in support of or against resistance training on individuals who have a traumatic brain injury. So, I mean, just do what you do. If they got medical clearance, put them in the training, depending on what kinds of symptoms and effects they have that are residual of the injury. Make sure your instructions are clear. Maybe you have to repeat them a couple of times, but that's the long and short of it. It depends really on how significantly they're affected. Spinal cord injuries. So this goes back to, again, if you're in my class in 2018, we watched Murder Ball. And I know a lot of you are like, oh, I'll probably never deal with anybody like this. Well, you might. And spinal cord injuries is what we're talking here. SCI, an injury or disease process of the spinal cord, which can result in altered motor, sensory, or autonomic functioning. Injuries of the cervical region, so looking at the cervical spine, right, closer to your neck, affect the upper and lower extremities as well as the trunk, and that produces a state of tetraplegia, otherwise known as quadriplegia, which again is impairment in all 4 limbs, upper and lower, as well as in the trunk. So this says paralysis. It's not necessarily paralysis, okay? It is impairment, significant life-altering impairment in all 4 limbs. If you have injuries to the spinal cord a little bit further down in the thoracic region or the lumbar region, that can lead to paraplegia, which is paralysis or motor deficit in the lower extremities and some portion of the trunk. Pretty much depending on the height at which the injury occurs, is going to affect pretty much everything underneath it. That's a quick rule of thumb. Again, maybe not exact scientific, but if you're looking for a quick way to remember it, that's as good as any. Further described as the designation of the injury, it happens again where the vertebral level of the injury and the completeness of the functional deficit. So whether it's full paralysis or just impairment. From just an anatomy standpoint, the spinal cord is protected by the vertebral column. So all those individual vertebrae, right, those bones and all the discs and everything, they contain the spinal cord. It is in there. And so it does not necessarily, however, have to go through those in order for there to be a spinal cord injury. Injury can occur even with the vertebrae completely intact. An injury can be a transection, where the cord is completely severed, or it can be a contusion, a bruise. And if it's bruised or something like that, further damage after that initial injury can occur due to swelling. Again, whenever we go into an injured state, swelling occurs. Most common cause of a spinal cord injury is going to be car accidents, and believe it or not, sports activities result in 8%. Now, I know that sounds like that's a low number, right? Because in the whole pie, 100% is 100%, and only 8% is sports. But I'd say that's pretty close to 10%. That's 1 in almost every 10 of these types of injuries is a result from some kind of sporting event. So that is our world, and that's a pretty significant number. So something to really keep in mind, just in terms of how spinal cord injuries happen. Not a whole lot here for medications in terms of the spinal injury itself, but for pain, maybe some NSAIDs. There's nothing you're going to be able to take, though, to reverse the injury. Depression is sometimes a side effect, so then maybe they'll take some antidepressants. Again, and more SSRIs. If they have issues, which they will if they're paralyzed in the trunk and in the waist down, diazepam for bladder control, depression, autonomic dysreflexia, so overactive autonomic stimulation, and lots of side effects as a result. These can significantly reduce the ability of the individuals to exercise vigorously or to maintain balance, besides what the injury already does to them. Functional capacity is limited, so for them to even do anything, it's more limited now. There are motor deficits, and there's less available muscle to work with. Again, depending on how severe, where it happened, that obviously will impact the extent of their limitations. But there are a lot of sports and activities that these guys can do, these guys and gals. Look up information on the Paralympic Games. That's going to be something that would be really beneficial to you if you wanted to see, well, what else can they do? Well, a lot, actually. They might have some autonomic dysfunction as well due to cardiovascular limitations, and that's if it's above the thoracic 4 level. Also, the venous return from paralyzed limbs can be impaired. That requires a higher level of oxygen extraction and leading to earlier local muscle fatigue. So just even the muscles and trying to get everything back to the heart and pump back away, the muscles might get more fatigued at the site of where the muscle is, just because that return is impacted. However, you can improve their cardio, their peak oxygen intake with the upper body ergometer. High intensity upper body resistance training paired with low intensity arm cranking has been shown to improve their strength significantly. There's your recommendations, again, located in the book. You can track it down. 8.7, that's going to be a few pages further on down the line. Specifically, we have that all the way on page 298. You might be limited to arm crank exercises or reciprocal press pull exercises. Something that you want to make sure that you do here is don't push them too hard and make them too tired, because the only muscles they have that might be working, right, and the only limbs that are working, if you overload that musculature, now they're going to be so sore and tired that they're not going to be able to do things in their daily life, like helping with their wheelchair transfers, getting in and out of it. And so there is an increased susceptibility to overtraining, so don't overdo it. Use antagonist muscles to those used in daily movements. Those muscles will probably be pretty strong anyway, so work the opposite side. Torso stabilization will likely be difficult or impossible depending on impairment. So you might need some stabilizing devices, straps, that sort of stuff to kind of help secure them to whatever equipment you need to do so they can execute these movements. There are machines modified for wheelchair use. They typically supply wrist straps, and those will attach at the wrist versus having to grab a bar or grab an attachment, and then they can still pull and use those muscles. So that's adaptive equipment that's available. There you see the site at which, if the injury occurs at any part here along the spinal cord, corresponding with all the different vertebrae of the spine, that tells you whether they be experiencing quadriplegia or paraplegia. Getting towards the end here, epilepsy. It's a collection of disorders characterized by recurring seizures caused by an excessive electrical discharge in the brain that disrupts the normal pattern of brain electrical activity. And you can go over to the Mayo Clinic website to give you all the different signs and symptoms. It's a bit more comprehensive. It's defined by at least 2 unprovoked seizures more than 24 hours apart. So not just one in isolation, it's 2 in some succession of time. Or 1 unprovoked reflex seizure and a probability of further seizures similar to general recurrence risk after 2 unprovoked seizures occurring over the next 10 years. Diagnosis of an epilepsy syndrome. They've got to be seizure-free for the last 10 years, no meds for 5 years, completely resolved. So this is something that stays with you. It has to show a complete resolution of symptoms and issues for a long period of time after. Seizures are, if you've ever seen one in person or on TV, a lot of different outcomes, maybe some blank staring and jerking movements. Could lead to full-blown convulsions that lead to unconsciousness. It really depends on the area and the amount of the brain that's affected. The duration of seizures range from seconds to minutes, often with the disorientation after the seizure ends. They are classified as either primary generalized, which is involving both sides of the brain, or partial focal, and that's only going to affect one part of the brain. It can be triggered by a number of different things. Certain foods, perhaps, when you eat them, changes in hormone levels, stress can bring on seizures, sleep patterns, and photosensitivity. That's why certain video games come with warnings, or flashing lights, or going to a live stage show. Those can all trigger an epileptic event, a seizure. Causes are unknown. Again, go to that Mayo Clinic link in order to find out more. Determine the source, if possible, is important to determining proper treatment. Right, here's all their meds. They need to take their meds regularly. Anti-seizure or anti-epileptic meds are the most common. They can help to control seizures in most individuals. There are There are side effects, however, that could impact the work we need to do with them. Now, weight loss from exercise may necessitate a change in dosage. So you might be working with someone, they do so well that they might have to actually change the amount of medication they get, but a physician should be consulted. So just because they get lighter doesn't mean we say, oh, take half of your medication. No. Go back to your doctor, get reevaluated, and let them alter your dosage. Now, people who have epilepsy, they have a lower resting metabolic rate and resting oxygen consumption. So they're not burning as many calories as the person that does not have epilepsy. They also have decreased EEG activity during and following exercise. Exercise does not decrease the rate of seizures, so we're not that helpful, but we can help with your peak oxygen intake, strength, body composition, and quality of life. Biggest thing we need to be worried about with folks that have epilepsy is the issue of a seizure happening during or immediately after exercise. That's why getting CPR and maybe first aid certified, really the first aid stuff, more hands-on even than what we do here, is good because you want to know how to be prepared for someone that has an epileptic event. Exercise-induced seizures are rare due to decreased brain electrical activity, and there's a couple things about care we'll talk about. But for what we choose to give them, it's just like giving an exercise program for someone that's just a deconditioned adult. They're typically less active, so we treat them normal. Otherwise, we're just worried about what happens if they have a seizure during your session, which is possible. So for first aid, just a couple of the last things here before we close this all out for good. Allow the seizure to proceed. So don't try to stop it. You can't. Don't put anything in or near their mouth. Don't go near it. It's going to clench shut. That's not a situation you want. But depending on what's going on, you might want to stabilize their head and protect the head from any injury from the seizing and the involuntary movement that's going on. Get an emergency crew out there. Call the 911. Especially if they have difficulty breathing, if the seizure lasts more than 5 minutes, multiple seizures without regaining consciousness. If they're pregnant, injured, diabetic, look, if somebody's having a seizure, I'm calling. I'll let them sort it out from there. If they're frequent seizures, avoid exercise that might result in injury if a seizure occurs, so including certain weightlifting activities, treadmill activity, and water activities. If you know that those are something that can happen a lot, don't put them in positions where if they suddenly have one, it'll be worse for them. Thank you so much, everybody, for being patient, going through this. 1 hour in the can. That's neuromuscular conditions and disorders. We will see you on the next one.